Thanks, Amy. Appreciate the invitation to be here. I want to begin by acknowledging our research team at UCSF. Here we are with a cake celebrating completion of enrollment for our first long COVID clinical trial a few weeks ago. But it's really a pleasure to work with them every day and is a lot of fun. Here are some disclosures. So our program in San Francisco is called LINC, which stands for Long-Term Impact of Infection with Novel Coronavirus. And LINC launched, really in the earliest days of the pandemic to understand what happened to people after they had COVID. So we opened in April of 2020, and probably within 2 weeks of opening, we began to encounter people with what would now be called long COVID. We've been in continuous operation since that time, have enrolled over 1,000 people, conducted over 5,000 visits, banked tens of thousands of biospecimens, and support a lot of collaborations, including with many people in this room. We've been fortunate since 2022 to be part of the NIH Recover program. And since 2022, with support from PolyBio and others, we've launched and built out a tissue biopsy program, an imaging program, a clinical trials program, and are now beginning to consider our expansion to other infection-associated chronic conditions. So I'm mostly going to talk about post-acute antigen persistence and long COVID, but I wanted to just spend a moment and reflect on that. All of this post-acute stuff is really happening after people have a well-known acute infection. And I think often we focus so much on the post-acute phase that we neglect to think about the first few weeks and how that influences what happens later on. So these are some data from our acute program that is attached to LINC called Find COVID, which is a CDC-funded program led by Dan Kelly, where we're actually able to enroll people within a few days of acute infection and then follow them long-term in LINC for months or years. And what this analysis shows is that some of the action that happens during the acute phase of COVID actually really matters in determining whether people are destined to go on and develop long COVID or not. And so what you're seeing here is that the maximum infectious nasal viral load in the first 3 weeks post-COVID is associated with later presence of long COVID at 3 months. And then the overall burden of PCR positivity later in the acute phase is also associated with presence of long COVID at 3 months. And so just want to acknowledge that the early events, I don't think we really understand exactly how they are important, but they are likely to be important. And others in this room, including Annie Antar, have published nice papers connecting acute and post-acute COVID. So this is a review from Dr. Proel here that was published last year that cataloged all of the various studies of SARS-CoV-2 persistence, which at the beginning of the pandemic, we really did not think was going to be of importance, but turns out that it might be quite important. A lot of these studies have significant limitations, so they're often very small cohorts with short interval of follow-up. Many of them are just a couple of months of follow-up. Often they're highly enriched for immunocompromised patients who we know can shed for longer and really have something different, which I think is kind of chronic acute COVID. There's often unclear documentation of when people were vaccinated, which can affect the outcome measures, and if and when people were reinfected. But the main limitation of a lot of these earlier studies has been that they've only studied people post-COVID. They've not really included significant numbers of bona fide true negative controls from before anybody had COVID. So Dr. Morazzo stole my thunder a little bit this morning, but that's okay. So this is the paper that we recently published in Lancet ID, where we studied 250 true pre-pandemic controls. It's impossible for these people to have had COVID in 2015. And we compared them to samples collected from about 170 people across hundreds of time points post-COVID, up to 14 months after the most recent infection. And really important is because this program launched in 2020, the vast majority of these specimens were collected before a vaccine went into somebody's arm ever. And during this time period, reinfections were exceedingly rare because a lot of this was sort of pre-Delta. And then in collaboration with David Walt's lab down the street, we performed single molecule array assays. You can see the characteristics of the two cohorts here. I will note that they're both enriched for people with well-controlled HIV because we also have sort of a role in HIV research. So what we saw was that the false positive prevalence of antigen detection in the pre-pandemic samples was 2%. So the specificity is 98%, which is good, but not perfect. But then when we looked across the various post-acute time periods, we observed higher prevalence of antigen detection in each of the periods up to 14 months post-COVID. People who had been sick enough to be hospitalized with COVID were twice as likely to have this as people who were outpatients. But even among those who were not hospitalized, those who self-rated themselves as being very sick during acute infection were about 3 times as likely to have this than people who said that they had very mild COVID. And so to me as an infectious disease clinician, that I think is very biologically plausible. It makes sense to see those relationships, and it makes me convinced that this is real. So a summary of this study is that I think the use of the true negative comparator really substantially strengthens the evidence here. I think the association with the severity of acute infection may be really important, sort of hearkening back to that first slide that I showed. You know, it's possible that people who have post-acute antigen persistence simply have more virus around at primary sites of infection in the nose or the lungs during primary infection. But it's also possible that that higher burden early on can kind of distribute and seed distal sites, which may be immune protected sort of sanctuary sites, and we don't know. Probably the most important thing to understand about this is that even among the people who have this, we do not measure it consistently, which is kind of maddening. This could be due to an assay sensitivity issue. Many of the values are over the cutoff, but not hugely so. And so it may be that more sensitive assays are needed. It could also be that different biological factors, whether somebody has eaten or exercised or had a bowel movement or hormone release, could determine whether an antigen is detected at a particular time point in a particular person. For example, maybe these are sporadically released from tissue. And then just to say, the evidence linking antigen persistence to long COVID is not particularly strong. I think we are getting there, and we need to do a lot more work to get there. It's going to be really important to pin that down if it is the case. So this is why the evidence is not that strong, which is that none of these studies were necessarily specifically designed to answer this question. So this is showing the 170 so people in that study I just showed you. And you can see that on the right side in dark blue, people with bad long COVID seem to be more likely to have antigen detected. But we only had 17 people in the study who never had long COVID. And I really think that we need to bulk up these studies to study hundreds and hundreds and hundreds of people and specifically enrich the cohorts for groups that have truly never, ever had this to pin down that answer. So measuring free-floating antigen in plasma is great, but it may not be the most sensitive measure. And so people like Mark Painter and John Weary's lab at Penn are looking at other types of proxy measurements to kind of orthogonally look at this. And so what you're seeing here is the proportion of activated SARS-CoV-2 specific CD8 T cells in people during acute infection who have fully recovered in the middle in red, and in people with long COVID. And you can see that 25% of people with long COVID have evidence of activation, which is potentially consistent with ongoing antigenic stimulation. These cells, in theory, are trafficking into or out of the tissues where the antigen might be present. And we've actually shared longitudinal specimens from Link with this lab. And what they are finding is that people with consistent long COVID over a year have sustained activation across multiple time points to a much greater degree than people who have fully recovered from COVID. We recently completed a project with Nadia Rowan using CyTOF, where we saw a similar pattern of SARS-CoV-2 specific CD8 T cell activation and exhaustion, and other groups, including the group at Yale, have shown this. But what was really interesting about that study, which I don't have a lot of time to go into, is that SARS-CoV-2 specific and total CD4 T cells actually had increased evidence of surface expression of tissue homing markers, suggesting that whatever was going on to activate the CD8s could be driven by processes happening in tissue. And so in part due to that, we decided, blood is really only a snapshot, so let's look across a person's whole body to figure out what's going on in the tissues. So we're fortunate at UCSF to have an imaging program that's led by Tim Henrich, shown here, and Henry Van Broeklen, in which we administer a novel immune tracer that basically lights up activated T cells, and we can look on a whole body level at where T cell activation is happening. So we, as a pilot project, studied 24 people up to 2 years post-COVID. 18 people had long COVID. 6 people had fully recovered rapidly from COVID, and we had 6 pre-pandemic control scans to which we compared these individuals. And what we saw was that people who had COVID really lit up on these scans for a year or even 2 years after they had COVID. We saw increased T cell activation in neurologic tissues, cardiopulmonary tissues, lymphoid tissues, rectal wall, and even the bone marrow. Some of these tissues, the enhancement was most pronounced in people with long COVID, but many of these tissues was lighting up even in people who didn't have symptoms, suggesting there may be kind of a new immunologic set point that develops. So based on that work, we wanted to look at what was actually going on in these tissue spaces, and over the last year have launched, with support from PolyBio, a pretty large tissue program in which we're doing gut biopsies, lymph node FNAs, CSF collections, and bone marrow biopsies. We did our first 2 bone marrow biopsies last month. And this gives us a direct look at what's going on potentially with regard to that immune activation. So I'm only going to talk about the gut program, but we do flexible sigmoidoscopies in people post-COVID, and we actually mount the samples on the same slide as a pre-pandemic control specimen so that we don't have to deal with batch effects and staining. And then in collaboration with Tim's lab, we do assays like RNA-scope and immunohistochemistry. So what you're looking at here are control specimens. This is gut tissue, and the signal will be in green. So you can see there's not much green on the control background slides. But when we look at people post-COVID, they light up. The top person is 6 months post-COVID with long COVID. The bottom person is 2 years post-COVID with long COVID. No known or suspected reinfection in either case. The signal is in the lamina propria, not the epithelium, so not really consistent with acute infection or reinfection. It's in that sort of connective tissue immune surveillance layer. And it seems to be in areas that are dense with CD68 staining, which suggests myeloid lineage immune infiltrates. So the question that follows from that is this actually just fossilized junk, or is this doing something? And so to try to begin to answer that question, we repeated these experiments on adjacent tissue sections using both sense and antisense probes to see if we could identify double-stranded RNA, which you can see in 3 of the 4 slides shown here. That should really only be present if virus is sort of actively going through the life cycle. There are a lot of caveats, but really interesting and I think provocative that we're seeing this in at least a subset. So based on those observations, we really believe that this is an important thing to chase down. Others believe that too. And we're fortunate now to have a growing long COVID trials program. We are participating in the recovery clinical trials in our site for Vital, which is going well, and we separately have within Link a number of smaller kind of phase 2 proof of concept mechanistic studies that I'll talk about briefly. And then we're also going to be part of this large NIA-funded study called Reverse LC, which is an immune modulator study with baricitinib. So our first clinical trial was of a SARS-CoV-2 specific monoclonal for people with established long COVID. This was funded by the Patient-Led Research Collaborative in collaboration with Arium Therapeutics and additional support from PolyBio. And we took 36 people and randomized them 2-to-1 to get a single infusion of this monoclonal, which worked against all variants through the fall of 2022. So people had to have long COVID attributed to an infection before the fall of 2022. It has a long half-life, so a single infusion is thought to last 3 to 6 months. And we are following people up to a year. Almost everybody has completed the primary endpoint at this point, and many have completed the 6-month time point. And so we're hoping to have an initial sort of high-level readout at the end of the year. And then layered on this study, we're actually performing imaging and gut biopsies pre and post intervention, and over half of the participants have opted into these more kind of intensive studies. So I think we'll hopefully learn quite a bit from that. And then last month we launched Prevail LC, which is a study of ensitrelvir, the Japanese protease inhibitor for long COVID. And so this is similar to the Paxlovid studies that are ongoing, but we take people who have long COVID, randomize them 1-to-1 to a 5-day course of ensitrelvir. Ensitrelvir has a longer half-life than nirmatrelvir, so it's thought that they have therapeutic levels for 10 to 12 days. And then the follow-up time points are at 10 days, 30 days, and 60 days. And again, people in this study are doing pre and post gut biopsies, lumbar punctures, and imaging. So I wanted to take just a couple of minutes and reflect on some issues that have come up in the context of these trials. I'm only going to talk about a couple of issues because there's not time to talk about all of them, but I would love to talk with you about more of them during the break. So the first issue is the interest is totally overwhelming. For our first trial of 36 people, we had a wait list of almost 300 people. It feels terrible to turn people away. The second problematic issue is heterogeneity and how to select participants. And so the question I get is, you're doing studies of viral persistence. Why are you not selecting people who have viral persistence? And my answer to that question is we can't really use the current assays to do that. I don't think you could do that in a reliable way because we don't really understand how to interpret the results of a lot of these. So I hear people saying, oh, well, if the antiviral trials or the monoclonal trials turn out to be negative, that means that we should abandon this line of inquiry. And I think that that is like 1,000% untrue. All of these trials have to be read out with the caveat that we don't know going in who had antigen persistence. We can figure that out post hoc, but our ways of doing that may be imperfect. And so I think that that really just means we need to sort of chase this down more. And then the third issue, which is causing me a lot of stress, is on-study reinfections. If you're doing a study of virus persistence, hoping to clear persistent virus, it is a problem that the pandemic is still going because people are getting reinfected. 7 of the 36 people in our monoclonal trial have gotten reinfected over the course of the study, including 2 this week. Fortunately, only 3 of those were before the primary endpoint, but how do you, I mean, I don't know how to handle that. I'm going to skip these others, but we can talk about them later. So anyway, just to wrap up, I think it's important to understand what's going on in the post-acute phase. And we're talking a lot about long COVID treatment, which is great, but we're not really talking enough about prevention. There are still millions or more people who are going to develop long COVID, even if it is less common than before. Apparently, the level of SARS-CoV-2 in the wastewater in SF is like very high this week, which I was surprised to learn. So we need to do a better job of really connecting acute and post-acute events. This is a schematic for how I think, one framework to connect these things are, which is that SARS-CoV-2 causes both, burden of virus early on and acute inflammation early on, maybe that acute inflammation is sustained and causes long COVID in the absence of virus persistence. Maybe that viral burden that is established up front is what generates persistent virus, and that then causes downstream inflammation and all of the other mechanisms that we think are important in long COVID. There are a lot of efforts now shown on the right side of the slide to intervene with antivirals in the post-acute phase, with immunomodulators in the post-acute phase, but there are really no efforts to formally study how to prevent this biological cascade. And so I think I often talk about the post-acute phase, but I wanted to spend a minute and just ask, does treatment during early COVID prevent long COVID? Sure, maybe it doesn't reduce symptoms from 5 days to 4 days in a significant way, and people are running away from antivirals because of that. But we've not answered a single one of these questions about how early treatment affects post-acute antigen persistence and whether it can actually truly prevent long COVID. Maybe 5 days is not enough, and maybe we need to treat for 14 days or 21 days. And then all of this kind of goes back to the bigger picture, which is that there are all of these other infection-associated chronic conditions that are set off by infections that we are not treating. And so establishing a paradigm for this in long COVID could be transformative for all of those other conditions. So my last slide is that I think it's hard to ignore the data now that SARS-CoV-2 antigen can persist in immunocompetent people. We need more studies to tie the acute phase to the post-acute phase. We still don't really know whether antigen persistence drives long COVID or other bad things that happen to people post-COVID, but it's an intuitive thing to look at, and I think the rationale to study that is strong enough now. And then I think the hope is that if we can figure this out for long COVID, it could provide a lot of insight into other conditions like ME/CFS, chronic Lyme, post-Ebola, and potentially prevent and or alleviate a lot of suffering. So I'll end there with some acknowledgements. I want to specifically acknowledge PolyBio, Patient-Led Research Collaborative, and the NIH for funding our work, and look forward to the Q&A. Thanks.